Okay. So, management of shoulder instability in overhead athletes. So these are my scientific disclosures. Shoulder instability in this kind of athletes is really a common problem. And sometimes it's because of trauma, but this is not the rule. And sometimes, I would say most of the times, it's because of chronic overuse or microtrauma. And when we're talking about overhead athletes, we mainly refer to baseball athletes, volleyball athletes, swimmers, handball athletes, tennis players, and javelin throwers. So these athletes are more likely to present with more subluxation, although any type of instability can occur in this type of athletes. And don't forget that the pressure that these athletes put in their shoulders is really very high. Let's take an example of the volleyball. The kinetic forces about the shoulder are really very, very high, and the highest forces is during the spike. I was a volleyball player, and I can assure you that I had a lot of shoulder injuries during my career, and this sport is really very, very demanding. Like the baseball, the throwing motion is a very, very demanding motion, and it has been studied very well, and it requires a balance between motion and stability, and unfortunately, a lot of problems can arise because of this motion. Most of the times, these athletes have excessive external rotation, and this, as a result, has an abnormal contact between the calf and the glenoid, and that's why a calf pathology can exist in these patients. On the other hand, this increased external rotation is an adaptive change that allows these athletes to improve their performance. If a baseball athlete or a volleyball athlete do not have enough external rotation, then his performance is really not so good. However, this increase in external rotation is most of the times the beginning of a vicious cycle, and this is because this increase in external rotation leads to repeated microtrauma in the anterior structure, and this leads to contracture of the posterior band of the inferior glenohumeral ligament, and this stretches the anterior glenohumeral ligament and the anterior capsule. And as a result, you may have the so-called symptomatic anterior instability, but not most of the times a frank dislocation. Because of the increased anterior translation and all these things, the anterior labrum tears by time, and this can happen even with or without the so-called internal impingement, and these patients can develop a slap tear or an anterior labrum tear gradually by time. So this is an example of a javelin thrower I operated some years ago. He is 25 years old, and his main symptom is pain, pain, pain. And as you can see, the detachment of the labrum starts from the 10 o'clock position, and it goes until 6 o'clock position. Once again, no frank dislocation in this athlete. So regarding history and physical examination, these athletes, once again, have most of the time pain. It has been described by Boileau as the unstable, painful shoulder, this condition. And once again, most of the time, there is no history of dislocation or even subluxation. So in these athletes, the most common complaint is deep anterior pain, which is experienced during the late coaching and acceleration phase. And probably these athletes have these symptoms for a long time before they're seeking for a medical advice. Most of the times, these patients, these athletes have the so-called GIRD, the glenohumeral internal rotation deficit, which sometimes could be greater than 25 degrees in the in comparison to the non-throwing shoulder. And this, as we said, it's the beginning of the vicious cycle. They may have, of course, positive apprehension tests, or they may develop all kinds of instability, MDI, posterior instability. Especially volleyball players can have a sulcus sign, which is indicative of an MDI. And these are two examples of adolescent volleyball players who have posterior instability and sulcus sign. And once again, no frank dislocation, but the main complaint is pain. So regarding imaging studies, the MRI findings are similar to patients with a Bankart lesion. Most of the times, these patients has no other lesions. Hill-Sachs lesions are not so common in this population. And according to some radiologists, probably the MR arthrography is the best way to evaluate this type of lesions. So how we're going to treat these athletes? Initially, all of us, we will follow a non-operative management. And this is really important, especially when these athletes have no glenoid bone loss, have no other concomitant shoulder injuries like rotator cuff tears. So if based on the MRI, we see that these athletes have no Sachs lesions, no rotator cuff tears, then we start in the beginning conservative. And it's very important to teach them the so-called slipper stretches exercises in order to improve this internal rotation deficit. And most of them will respond, especially if the symptoms has no more than 2 months, then these patients, at least in the majority of them, will respond to this treatment. Of course, we have to do in combination with rotator cuff strengthening, and if most of them respond well, then we will continue like that. Otherwise, if non-operative treatment fails to relieve their symptoms, then we may think of surgical treatment. And of course, there are a lot of technical considerations among surgeons how to operate from a technical point of view these patients. So in most of them, what we're doing is anterior capsulorabular repair, either the so-called 180 capsulorabular repair or the 270 capsulorabular repair, which is, I think, more applicable to patients with MDI laxity. What about remplissage? This is a big dilemma in these patients, and you always have to think that the main purpose in these athletes is not to reduce the dislocation rate, but to allow them to go back to sports, and for this they need the external rotation. So if you add a remplissage, then most of the time these patients are not able to go back to their sport, which is once again the main purpose of the operation. So what I'm doing in most of these cases is the so-called 180 capsulorabular repair. I usually start from the anterior part of the shoulder, and then I plicate the inferior part of the shoulder without suture anchors. I already placed, as you can see, the anchors in the anterior part of the glenoid, and then proceed with the capsulorabular repair in the inferior and posterior part of the shoulder. So in these cases, you don't hopefully restrict the external rotation, and these patients, these athletes are able to go back to sports. Let's have a look at the results. This is a very important study which evaluates the effect of remplissage in this kind of athletes. As you can see, 2 out of 3 were not able to return to the previous activities. So this is, for me, a very, very important message when you have to treat an athlete like that. On the other hand, even if you do a capsulorabular repair, the results are still not so good. 1 out of 3 is not able to go back to sports. Probably the best results in the literature is provided by Park et al., who report an 82% of return to sports after capsulorabular repair in about 8 months after the operation. What about Latarze? You heard before, Anna Katerina, that Latarze is probably a very good operation regarding stability, but unfortunately, even with Latarze, these athletes sometimes are not able to go back to sports. So pay attention on the type of procedure that you will choose when you have to treat these patients. Once again, the shoulder instability in these overhead athletes is a special problem. This is because the diagnosis is not always straightforward. Most of the time, these athletes do not report a frank dislocation. And secondly, because surgical treatment should provide stability and at the same time a normal range of motion, because the aim of surgery for these athletes is to go back to sport, not to prevent, like the other population, another dislocation. So in conclusion, it's a complex issue. Of course, initially we have to try conservative treatment, especially when there are no associated lesions in this shoulder. And if conservative treatment fails, then you have to go for surgical treatment, Bankart repair with augmentation of capsulorabular repair in the inferior part of the shoulder, no remplissage, no Latarze, at least as a first choice. And then you will give an 80% chance for these athletes to go back to sports. Although this is a shoulder conference, I would like to invite to the next ESCA all-about course about the anterior cruciate ligament, which will take place in my place in 1 month from now. And of course, don't forget our big congress in May in Milan, and hopefully we'll see you there in 2 months. Thank you very much.